We are learning how better to use some of these drugs with more experience. For example, the drug ibrutinib we know is metabolized through the CYP3A pathway, and so we counsel our patients to avoid drugs that are metabolized through the same pathway, because if you get a competition with drugs that might be metabolized by the same pathway, or there are some drugs that might antagonize that pathway, then we can accumulate higher concentrations of the drug and making the toxicity profile something we have to consider. Alternatively, we can have drugs that might enhance the metabolism of drug, and therefore we don't have the drug being as active as it should be. So I think with ibrutinib, we're coming to understand how best to administer it, what drugs to avoid, and for those patients who are taking drugs that might interfere with this pathway, there are new recommendations coming out with how to dosage modify the amount of medicine to give so that you can't co-administer drugs that are metabolized by the same pathway. I think that's important. As we gain greater familiarity with these newer drugs, we are also gaining ways to be able to incorporate them into the other therapies that our patients require, and not just have patients who don't require these other drugs. As you know, we don't live in a perfect world, and sometimes you need to take another drug for another condition, for example, a fungal condition or fungal infection, and you can't stop that medication just because you want to take ibrutinib. So these are new practice guidelines that are coming down. I think with regard to venetoclax, we talked about the need to ramp up, and I think that it's clear that this is protected patients. We've not seen any major calamities as they saw early on when patients actually succumbed to tumor lysis syndrome. Fortunately, we haven't seen that, and I think people are much more attentive now to monitoring for the signs of tumor lysis and jumping right on them so that you can mitigate the risk of it getting worse. I think, though, that what we're trying to see is how we can make the risk into a low risk category for those patients with lower tumor burden, which is to say a lower white count below 25,000, or a tumor burden that is below a certain size that you can monitor either by exam or CT scan. For patients who are low risk, they can start therapies such as venetoclax even as an outpatient, but they have to be carefully monitored in the clinic with each dose increase. But it's safe to do and doesn't require the hospitalization, which is complicated and sometimes hard on the patient and the patient's family.